there's all kinds of things you can talk about. Um, my mother-in-law was a farmer's daughter. She grew up on a farm, and she would understand this. But farmers in most parts of the world keep seed corn. They keep seed from their former products. And I just want to kind of. So, who are you? Who are we? What shall we become? Help create the future of healthcare, lest they create a mess. A lot of times in the doctor's lounge, I'm hearing people talking about what they are going to do. And when they is kind of this amorphous thing. It's either the government or the hospitals or Blue Cross or who knows. People who like basketball, who play basketball, know that a good player can out-rebound a great player by thinking ahead, by getting in position, and boxing out, if you will, the opponent from getting that rebound. So we have to think about that. I want to provide an overview of the healthcare environment and why creating value is important. I want to discuss the challenges we could face if, because of this environment change, steps we might want to take to be successful in this environment, and then talk about how going it alone, all by yourself, with our self-reliance that we have as physicians, and we can do anything, but you have to be in position in order to do something. What we can do together to raise our value in the marketplace, and in some sense, why we are really all in the same boat, especially those, everybody here that I see is in some sort of private practice, and we rely on each other. Why examining where your contracts exist may lead to better choices. So value-based healthcare delivery, there's all kinds of way to look at this, and there's some questions about it. And I'm quoting people who are smarter than I am, because it's always good to do that. Achieving high value for patients must become the overarching goal of healthcare delivery, with value defined as the healthcare outcomes achieved per dollar spent. This is from Porter. And stakeholders often have myriad conflicting goals, including access to services, profitability, high quality, cost containment, safety, convenience, etc. And he's talking about aligning reimbursement with value. Really hard to define value. It's cost, quality, patient experience, and what gets counted and what doesn't. But our present healthcare system does not reward value. It rewards volume. So there probably needs to be something changed. Another way to describe value-based healthcare is a simpler concept, the so-called triple aim: cost, quality, patient experience. So who cares? Well, that's how we're going to make a living as we go forward. That's an important thing to pay attention to. So I hear when we talk about this, people talk about bundling. And so the example that's always used in bundling is orthopedics. Because orthopedic surgeons have a reputation, I want it my way, and so on and so forth. I suppose everybody who does a surgical procedure is that way, because even little things I do in the office, I want it a certain way. It's just, you want that environment controlled. So they're saying, gee whiz, if we get, instead of joints from all these different manufacturers, we can streamline that, we can get cheaper joint costs, similar order sets, similar ways of doing things. We're going to save money, and we'll squeeze that money out, and lo and behold, there's extra money for somebody. Well, that happens once. There's very few iterations on that. Once they get the cheap joint, it's not going to go down a whole lot more. Once they've done some process improvement, it's not going to go down anymore. And a lot of that's already happened. A lot of that's already happened. So after 1 or 2 years, there's no more savings. And what about the patient who goes outside the bundle? If you're a primary care doctor and they will maybe stop consulting us, I mean, that's not necessarily a good thing. They probably need to consult us for a number of medical issues, if not for patient satisfaction. And real savings might occur from not doing that surgery in the first place. I mean, we're talking cost savings, not doing it in the first place. And that's where primary care docs come in, and that's where, if you will, enlightened specialists come in. Crying is all right in its way while it's lasts, and that's what I hear in the doctor's lounge, the crying. But you have to stop sooner or later, and then you still have to decide what to do. And it's kind of ours to decide, because we are the healthcare experts. All the they out there are not healthcare experts. We are. We have to decide this. We have to give the best we can to our communities and our patients and create value. And when you create value, you profit from value. So keeping a referral base for specialists, that's why it's important. Because if the hospital or some other entity controls all the primary care docs, guess what? They're not, if you will, interested in the value of your services. You know, I see Dr. Yu here. You know, why do I send my patients to him, right? Why did I send my mother to have him to look at her eyes, and my father? Because he's a good doctor, right? And the hospital is not going to realize that value. They're not going to realize that value. I realize that value, and we want to keep those relationships as they should be. We need to create value for our primary care practices. These times are such that primary care practices are being bought, but for almost nothing. Almost nothing. I mean, you're creating value. You're bringing millions of dollars each primary care doc to the hospitals that you go to. Millions of dollars of value to the community. Not much comes back to you, and at the end of the game, you might sell it to a hospital. Maybe that'll work. I don't think so, because they can't all be for sale, and quite frankly, they're cutting off our pipeline anyway. They're hiring 95 to 98% of family docs coming out of the pipe. Similar with primary care internal medicine, similar with primary care pediatrics. So we need to create value, because we own things also, you know. If nothing else other than the processes that work well in our offices, the equipment we have. Maybe we own an office building. Maybe we have a stake because we have kids who are in healthcare, and we want to make sure it's good for them. And our specialist colleagues, we have to think about that. Our specialist colleagues need this, and we are symbiotic. So we need to bring all the resources needed to deliver high quality care to primary care physicians and specialists to their practices, and bring value to the community and profit from that value. A rule in business: how you make profit is by creating value. So if you can create value in a process of business, you can profit from that. If you don't create value, it's a commodity. You're selling a commodity. And we should profit from that value. But it seems we will let everybody else do this. Everybody else, except us, we're letting all the primary care docs go to the hospital. So we're walking the talk. I mean, we have extraordinary cost savings in Blue Care Network and have. Very, very good quality. Medicare, I'm proud of those quality numbers. And it results in lower profits for hospitals, pharma, some specialists. I dare say not the ones that are here. And those who lose profits will not cede them without a fight. They're not going to give up getting all those profits. They want to make those hospitals bigger, not smaller. And they need to be smaller. And that's why they want to tie us up in relationships, whether they buy our practice, whether they have restrictive contracts that make it such that we have to see every health plan that they've contracted with in order to see their employees. I know of 2 entities that docs go to here that have that kind of contracts. So all they have to do is turn that on and say, you have to bring all your contracts over. They are selling people EHRs. So when I bought a practice, what was the most valuable thing I bought? No, when I bought a practice, it was the charts. I got the first shot at the patients. They came to my office. I had the charts. So what are docs doing? Oh, I'll get Epic, it's cheap. Who owns your chart? Think about it. They want restrictive relationships. They want to tie you up in knots. And maybe you're smarter than I am. And maybe you can figure out a way to work that out. And as an individual with this monstrous entity, you're gonna win in that negotiation. I don't think so. So we have other challenges while we're trying to create value. We have Senate Bill 68. Does anybody know what that is? Chris does. Senate Bill 68 is going to give nurse practitioners independent licensure. Now, apparently they just did this in Nebraska, but the studies haven't, and they think it's going to help in underserved areas. Well, who's in the UP? Family docs, pediatricians, internal medicine, and the nurse practitioners are in the hospitals, not in the communities. They're not. You can look at the numbers. But they're going to compete with us. Pharmacists on the west side of the state are doing strep tests and flu tests and treating people and doing physical exams. We have minute clinics. So hospitals create a waiting time for their drugs, which shouldn't take time at all, so that patients are sitting around and they can have their blood pressure checked, get their immunization, taking away our profits. And of course, hospitals are buying practices. Do you notice how many people are investing in primary care? I mean, it's not just one entity or two. These are kind of like primary care services. So why aren't we? Physicians aren't doing this. Are we crazy or are they crazy? So, like cost, quality, and patient experience, physicians who manage the triple aim will have higher remuneration right now, not in the future. Because the other thing is cost is really, really, really important. People going on the exchange, 98% are picking on cost, except my daughter. She went out and I said, you want this health plan. As cost between the plans, however closer, people are going to pick on quality. They're going to start discerning more, and health plans will figure that out. They're going to get closer to each other. Somebody's going to buy business always, but people, after a few iterations of this, will start looking at the quality of the individuals in the plan and the plan itself. Many of us, if you look at specialists like ophthalmology and OBGYN and dermatology, probably ENT to a certain extent, had to compete on the base of patient experience, how much our office visits were, and so on and so forth. Some things that are more episodic, like general surgery, probably not so much. A lot of that's covered by insurance. But people are going to start looking at this, and we have to accept that and adapt to that. So we are chosen. We've been chosen. Blue Cross Blue Shield with Blue Care Network is having an OSC-based health plan. And they're going to have 2 tiers. People who go to docs in the higher tier group get lower copays and deductibles. They go to lower tier doctors, higher copay and deductibles. So we've been chosen. We're a top tier group. AHA's on the track to get more than $40 per member per month from Blue Care Network, over $3 million. That's for 2014. $500,000 from HAP, about. So this gives us a competitive advantage, as I said, an accountable healthcare advantage. But delivering value is really hard, and it's an ever-moving target. So this starts to get hard, and this is where the seed corn thing comes in. We're universally chosen by health plans, pretty much. Any tiered thing, they want us in. They want us in as number one, but not universally by our docs. There's a lot of docs, and I who are in one group for this one, and another group for this one, and another group for this one, and you see that dilutes our effectiveness. It really does, because we get, for instance, from HAP and Blue Care Network, about $1.50 per member per month, someplace in there, and that helps fund the organization. Now, we do this, we use mostly that because we're trying to give the value back to the physicians. And we wanted to not have restrictive arrangements because we wanted to show that we're going to have value. However, other groups are using very coercive methods for doing this. So, for instance, Henry Ford Physician Network requires you to move over any contracts. Oakwood has that in their agreement, so that, say for instance, I sign up and I'm seeing their employees, and then there's another health plan, and another health plan, and another health plan, another health plan, and pretty soon I'm pretty deep. And oh, you want my Blue Care Network contract? What I'm making? Maybe $100,000 a year, more than I would otherwise. You want that one? How do I unravel that? You're in deep. It's hard to do. Oakland Southfield Physicians, Medical Network 1. And I'm not used to criticizing these other groups, but we have to. This is part of the thing. If you're an Oakwood Southfield physician and you leave the group, they're going to keep your money. They're going to keep your money. Docs are shocked when they get a check after they've left. They're shocked when they're retired and they get a check. But that's the way we want to be. We want to be that way. So UOP doesn't send out any money. And then United Physicians, which is the Beaumont one, right? And who knows what we might be dealing. It costs $1,500 a year to stay in that organization. $1,500. I think that's for PCPs. I think it's $2,500 for specialists. That's what I was told. I only know the PCP number for sure. So here it is. We're living off $1.50 on a couple health plans, and the other ones are taking the money. So group-wide efforts. So why is this a problem? Group-wide efforts benefit all of us, and here it is. We may benefit one of these other groups by the activities we do in your office because you're in one plan. Chances are we will. And so the money that's there for administration is less than what we would get if every doc were in every plan. And I don't want to say this is required, but we need to figure this out. How do we do this? And if we're going to be fair, we need to have people be fair back. So if I improve somebody's practices, they improve their quality, and all of a sudden they're reporting in Blue Care Network better, but they're in another group, Blue Care Network group, because we're working with them on HAP or in Blue Cross PGIP, because we've improved their office processes, we get no benefit from that. And the other groups aren't doing these kind of things. And it creates a sense that doing things that may advantage an individual practice that don't advantage our group's contracts is not worth it. But I dare say it is, because we need private practice physicians to survive. So we need to do things that are perhaps not just related to our contracts, but outside that. It will also make it impossible to replace your present medical director, at least with somebody who devotes as much time and energy as I do, because there's not the money there. I've been doing this largely because I want to. So this is worth saying, our mission, vision. You don't want to read this, but this was important work that the board did, and it kind of tells you what we think about the organization. I think these can change. I think they probably should change, and I think it's time for you to comment on this. Do nothing and nothing happens. Life is about decisions. You either make them or they're made for you. You can't avoid them. So that's why the board needs to do this. We need to be strategic with a strategic plan, but also we need to figure out where we're going, because if we don't, we'll probably get there. I think Mark Twain said that. So your board's been engaged, we've done strategic planning, we continue to weigh in on important decisions as a board. This is the best board in southeastern Michigan, bar none. 2 physicians, by the way, are leaving the board. I'm sad that I don't see them here. We have awards for them, and if they come, we'll do this. But Dr. Sachdeva and Dr. Mohi have served the Whipple board and the AHA board for years and years and years. They're going off, and I really am thankful for their input and their efforts. Another person leaving the board is Dr. Mahajan. He's had some health problems. He hasn't been a long-term member of the board, but a very helpful member. Our management team also looked at over 20 registries. We kind of went through this, probably 25, 28 registries, I think. Kind of winnowed it down to 8 or 10, and then winnowed it down to 3 or 4 where we got really deep, and we realized there's not a whole lot of registries that work well across a group. And what a registry is a device that contains all the HEDIS and or Medicare quality stuff, so that we can monitor it as a group, and then we can react to it as a group in a better fashion. Otherwise, we have to go to every practice and look at what they have and pull things from their EHR or their registry, and so it's not necessarily as efficient. We are an organized system of care. Blue Cross Blue Shield really wants us to have a registry. We've been talking them out of it because, but this isn't going to last forever. They're going to want us to have a registry even if it's a bad one. But that's going to cost some money. Now, if you don't know about the Blue Cross Blue Shield OSC thing, patient-centered medical homes get a 10% uplift. If you're an OSC, you get another 5% uplift. Or 10% uplift. If you're cost effective, you get another 5% uplift. If you have a care manager, you get a 5% uplift. So there's all these uplifts so that you can, as a primary care physician, get a fee schedule that's pretty good. We also have opportunities to promote specialists for uplifts in their fee schedule as well. And we've been successful in a number of regards with a number of practices with that. Oakwood Hospital has 10% of AHA's business, so Oakwood Hospital has to do some things that reach out to the community and help improve community care. Well, one thing I saw that was lacking was Oakwood was not connecting with primary care physicians or specialty physicians for lab interfaces. They were just saying, no, we're not doing that. So those of us who require labs, nephrologists, endocrinologists, oncologists, obviously most primary care docs, we need those labs so we can track quality. If we can't track quality, we don't deliver good quality. We don't look as good. They're making us bad by not helping us connect. So we're requiring them to connect to physicians for lab interfaces. A two-way interface, because meaningful use requires ordering capabilities. And so this is going to be happening soon. They piloted a system. It seems to be largely working, and we have a whole list of docs. If you want to get on that list, if you want to make sure you're on that list, talk to us, but I think you're on it already. And this is specialists and generalists. But if labs are important to you and you need an Oakwood connection, we can put you on that list. We've also had been reaching out to specialists. We have a couple folks who are reaching out to special offices. How many offices have you been to, Barman? Over 75 offices. Because this has come slower to specialists in the Blue Cross plan and elsewhere, but we want to be able to build processes that can help you deliver better care, if you will, have you eligible for fee uplifts as they occur, and also create cohesion within the group. Because we want to have, there's a concept called patient-centered medical home network. They're trying to explain. Basically, you have a home and it's in a neighborhood, that's what they call it, neighborhood. So we're all part of a milieu that delivers healthcare. We all need to interact effectively. So, and for the Medicare Shared Savings Program, MAG and their nonprofit CareBridge is assisting us with care management services for our Medicare Shared Savings Program. We're gonna pay them back when we make some money. If we make some money. We don't pay them back if we don't. In the goals, I was talking about strategic plan. We want to increase health plan lives. One of the best ways to increase them is to increase the ones that we have that you have that we don't have, so to speak. We want to recruit cost-effective PCPs, but you know, that needs to happen, and we've been doing that for years. We need to have AHA be the physician organization of choice for independent physicians in this market area. And the market area could really be southeastern Michigan. And then we want to increase our financial performance, our quality performance in these contracts, because that's important. And then we might want to start thinking about encouraging development of bigger group practices. Because we can do this kind of like an MSO service. We can start developing things that work together, help us work together. But we may be able to do better by saying, okay, you guys, you want to group up, we'll encourage that. We think that's a good thing. Create a collaborative relationship. Probably has to happen in primary care first, because there's so many HEDIS and other quality measures that are going on. Help PCPs survive and thrive in private practice, because if there aren't any PCPs that are in private practice, the people who are in specialty practice aren't in private practice anymore. Maintaining profitability, reducing their complexity, figure out ways to help them grow their practice, create shared services perhaps that might help small practices. Maybe we can, contract with somebody to do, that might hire their employees. We may be able to do group purchasing, etc. We're looking at some group purchasing right now for vaccines, and then moving on to other things. We need to help specialty care physicians also survive and thrive in this environment. And one of the ways to do that is to have adequate numbers of PCPs in private practice. And also do the same things we're doing for the primary care physicians for small specialty practices. So it's not hard to decide what you want your life to be about. What's hard, she said, is figuring out what you're willing to give up in order to do the things you really care about. So what do we really care about? What else should we do? Well, I alluded to it, the registry, a database, some way of tracking our quality. We're not going to do this for $1,000, $10,000. It's going to be close to $500,000, $250,000. It's not small, and it's going to cost a lot to maintain. That's where some of the money issue comes. If you have a carpenter, right? You have a carpenter, and you say, well, I really want to hire you as a carpenter. And you say, what kind of tools do you have? I don't have any tools. Well, we have a hammer, You don't have a saw? No, we don't have a saw. You can have the hammer. Maybe you can break the boards with the hammer. It just doesn't work. We need the tools to work effectively. We will need care managers to help patients get through transitions of care, to get the most cost-effective care, to help them make decisions that are hard for us to have them make. Patients take a long time to get into palliative care, a long time to get in hospice care. It takes a lot of our effort. And if we have care managers that are talking to families and getting them ready for things that are inevitable, because there's a whole lot of futile care. We have to stop delivering futile care when we can. We need dietitians. We have dietitians in the hospitals. I think it's the craziest thing in the world. Diabetic educators and dietitians in hospitals. Where should they be? Where should they be? They should be in the community. They should be in specialty practices and primary care practices. That's where they should be. Fitness coaches at the hospital? Are we kidding? The disaster's already happened. Pharmacists. We have clinical pharmacists working in hospitals. It's probably a good thing, but they need to be working for us. And we need to find ways to cooperate as PCPs, for instance, to share things. So say, for instance, we got a system so that we could do virtual visits, right? Virtual visits. And that's going to maybe be good because we can make the equivalent of a 99213 on those virtual visits. Blue Cross, HAP, a lot of health plans are paying for this. They don't want to go to the minute clinic because they can talk to you. And most of the time, when they have a viral illness, you just need to talk to them. But they won't pay us for a phone call, for goodness sake, but they'll pay us for the virtual visit. But we'll need to cover that. And how do we cover that without cooperation? Because I can't be on call 24/7 and I like to wear a t-shirt, right? Every once in a while I work in my garden. I'm a mess. I don't want to be on a video camera with somebody. So, but if we can share those things, that would be helpful. So similarly, can we cooperate amongst each other, specialists and generalists? So I talked about the contracting with a system for doing virtual visits. I just see all these things out there that are going to take away a lot of our easy visits. Really, patients who are more worried than ill, right? More worried than ill, who just need to talk to you so they can say, yeah, I can wait another day. They really want to see you, but it's Saturday afternoon, you're not in the office. They'll go to the Minute Clinic. They might go online with one of these services that are out there. They can get on their phone. So I think we want to capture those visits. We want to have patients adhere, build connections with the physicians in our group. So how to do that is a good question. I don't have the solution. That's just a thought. We need to encourage practices that wish to merge. And I'm wondering, could we create a system for loaning money to help people get a new doc in their practice? Could we do that? Just it came to mind. Different specialty organization chose things that may be really overused. What I found interesting is that primary care docs were really, really willing to cut off our nose to spite our face, taking away some of our profit centers, and the highest quality specialists eliminated things that they're not doing anymore. The highest quality, highest paid physicians eliminated things they're not doing in the West. But it's worthwhile looking. It's worthwhile looking because there's a lot of information there, and it might get you thinking about what should I do for this or this or this. So we need the resources, and the board struggles with this, and that's part of the reason I'm bringing it here. We receive much from health plans in terms of money, risk sharing, if you will. Some of this, some, maybe more, needs to be used as seed money, if you will, to plant the future. We need to be able to control our future. We need to get into the position to be, as a basketball player, to get that rebound. We need to be able to have ways to encourage docs to get their contracts all in AHA. We need to think ahead, plan for success, and not wait for distress. The typical physician management, wait for disaster and then manage. Let's get ahead of it. Let's not wait for disaster. And we need to look past self-interest and look toward group achievement. I believe I have. I think we'll achieve much more as a group together. And if we're going to sell our group, right? I dare say a whole bunch of us coming together to say we'll sell as a group to the hospital, they're going to come out better in that negotiation than one or two. Prosperity tries the fortunate, adversity the great. So these are difficult times. They are very trying times. But I think we can show that we are great. So you, not they, you are the solution to our healthcare conundrums. Empowering physicians to achieve value, the triple aim containing cost, quality, patient's experience. That'll be our path forward. That's going to be how we create value, how we profit in the future. And then we have to help each other do that. We have to help each other do that. We have to be able to look at things on the horizon that are going to chip away at our profitability and react to those things, like the Minute Clinics and so on and so forth. Pharmacists doing physical exams, that's one of those things that makes me laugh, except that it's so scary. And I can see the ENTs thinking, yeah, how hard is it? How easy are they? How many tonsillar abscesses are they going to miss doing those strep screens? We need to invest in your future, and we need to understand how to do that. The best way for an organization to know how to serve its customers is to hear them. we need to hear your voice. And that requires leadership. And leadership really, in many instances, means followership. That means following because being a group, going together, is a better strategy than going alone in difficult times. And it requires you and your efforts. And it was, is, always will be your responsibility for what they do to healthcare, what they do to us.